This is Joshua Rosenau from Northwestern University, and I will be presenting on the evaluation of the patient with chronic pain. Properly evaluating and managing these patients can be a challenging task. The patients are often complicated and have had a long history with multiple prior treatments and experiences with other physicians that may have been either positive or negative. They also have significant psychosocial factors in many cases and socioeconomic factors and expectations that may complicate treatment planning. Because of the amount of information that needs to be processed in understanding the course that these patients have been through, as well as to determine what the next best steps are, it's important to keep your evaluation structured. I find that this is often best done in a chronologic fashion. This includes processing information, including their prior records, including office notes, imaging reports, operative reports, and electrophysiologic studies. It is important to not just have the imaging reports, but also to see as much of the prior imaging as is possible, and to take as much of the history as possible to understand the course that these patients have been on before they reach your office. The evaluation may be divided into several phases, such as before the visit, taking the history, performing the physical exam, and then planning a treatment. Before the visit, it is useful to have the patient transmit as much of their prior records to your office as possible, including office notes, operative notes, imaging studies, and whether or not this is part of an ongoing litigation case or workers' compensation case. A referral letter from the patient's current treating physician is helpful in determining the focused reason for the visit. These patients may have multiple pain complaints, and understanding exactly which complaint you are being asked to handle is useful in making the visit more efficient. On the reverse, it is good to communicate to the patient before the visit a set of clinic policies and procedures. These establish ground rules such as a late appointment policy and how medication refills and paperwork for such things as disability are handled by the office. These ground rules help ensure that the staff in your office understands exactly how to manage these patients going forwards so that there is no confusion. At the time of the initial visit, it's important to understand what the patient's goals are for the visit. For instance, does the patient want to get to the state where they have absolutely no pain and they're running marathons, or do they just want to be improved enough to be able to get out of the house, do simple activities, and walk around? It's also important to understand what role you as the physician are willing to assume. For instance, are you going to assume the role of prescriber of chronic medications? Are you going to add any medications or subtract any medications to the patient's current regimen? Are you just going to serve as a consultant but not actively perform any procedures that you propose? Importantly, these patients often have a history that includes contentious interactions with prior physicians, and it's key to establish the trust of the patient so that they feel that whatever recommendations you provide, whether they be ones that they agree with or not, are all in the best interest of the patient and are done along the lines of the best available medical knowledge. A full history helps you understand the patient's complete journey. These histories may be long, and their journey may have been performed over several decades, and that is another reason why staying along chronologic lines helps you to best keep the information structured. When understanding the course of the patient's pain, it's good to know whether there was a specific inciting incident, was there an injury, accident, or other episode where the pain started, or did it just have a gradual onset over time, such as what we often see for spinal degenerative changes. Has the pain changed over time? What difference did any prior treatments make? Is this a person who responded very well to certain treatments, but pain just kept coming back due to progression of spinal degenerative disease or reherniation of discs? Or is this a person for whom no prior treatment, whether it be medical, interventional, or surgical, has ever made a difference in their pain? Depending on the answer to these questions, you may choose to have different plans. If the incident is work-related, and especially part of a workers' compensation or litigation claim, it is key to know this because you should take additional detail regarding the actual injury, when it happened, the time frame around when it happened, and the actions taken at the time and soon after the injury. For instance, if it was a work-related injury, did the patient continue to work? Did they stop working? Did they report it to a supervisor? Were they seen by the occupational health people at their place of work? If it was an automobile accident, was the patient evaluated at the scene by medical personnel? Did they go to the hospital either that day or a day after? And what was the relationship of the pain onset to any work-related or accidental injury? When taking history of the pain characteristics, it is good to both ask the usual standard factors for any pain complaint, as well as pay attention to whether the pain is dermatomal or follows a non-dermatomal pattern. Is the quality more in line with nociceptive pain, or is it a more neuropathic pain quality? For example, if someone presents with pain that is non-dermatomal and is associated with color change, swelling of the affected extremity, and the patient reports trophic changes and skin sensitivity, that may lead the physician down the lines of considering this as a more neuropathic pain rather than something from a nociceptive perspective. Are the patient's complaints and characteristics of the pain consistent with prior injuries and treatments? Or is there something inconsistent about this that should either raise a red flag in the physician's mind, or alter the physician's judgment as to the diagnosis? Most of these patients have been through a substantial amount of prior medical therapy. It's good to know how many different classes of medications were tried for the pain, and were these medications adequate trials? Meaning, did the patients take the medications at a dose or frequency that would be expected to be therapeutic? And if not, what were the limiting factors, such as various side effects, that prevented the patient from undergoing an adequate trial? What types of interventional pain treatments did the patient undergo? What were the patient's prior operative treatments? And, as previously stated, has anything at all provided substantial relief of the pain? There are multiple reasons why prior surgical therapies may have failed, including poor patient selection, an incorrect diagnosis, a poorly selected procedure for the diagnosis, surgical technical issues, and progression of degenerative disease. When taking the history, it is helpful to elicit whether or not the patient has other medical conditions which are associated with a higher risk of complications and medical problems such as obesity, diabetes, hypertension, hypothyroidism, COPD, and inflammatory arthritis conditions and fibromyalgia. When discussing these with the patient, it is important to understand whether they are compliant with treatments for these other conditions, and do treatments for these other conditions fail as well. In discussing their concomitant medications, it is important to understand if the patient has current treatment with combinations of medications that may be problematic, such as concurrent use of both opioids and benzodiazepines. To truly understand the impact of the pain on the patient's life, the physician can inquire about what a typical day is like for the patient. For instance, does this patient spend most of the day in bed? Are they still employed? Do they get things done around the house and outside of the house? Do they have a history of multiple dysfunctional relationships or physical or mental abuse? Are there other family members who have similar medical and or surgical failures? And does the patient use any illicit medications, period? All of these factors are associated with a poor outcome from any further interventional or surgical therapy. In the current environment, it is also important to ask about use of marijuana, since there are an increasing number of jurisdictions that allow medical or recreational marijuana or both. In addition, it is good to inquire about how many different forms of marijuana patients use. Patients with chronic pain all come with their own specific set of psychosocial factors, and these need to be discussed with the patient and considered in planning any further surgical treatments. Within the constraints of an office visit, it is sometimes possible to get a general idea of such things as depression, drug and alcohol issues, social and family problems, but often these are most seen in detail from a visit with a pain psychologist. Patients such as these are at risk for medication misuse, and understanding the signs of medication misuse that can be detected in an office visit are key for any physician to understand. These include requesting only opioids for pain, having a strong preference for shorter acting medications, obtaining controlled substance prescriptions from multiple physicians, using illicit medications outside of the physician relationship, general noncompliance, the observation by the physician that the patient is over-medicated, patients stating that they have lost their medications repeatedly or needing early refills, and patients not adhering to signed medication contracts. The physical examination of the patient with chronic pain should follow the usual procedures for any physical and neurological examination. Attention should be paid to whether there are signs of myelopathy or simple root compression. Even though the patient may have been seen by multiple other prior physicians and surgeons, the physician evaluating the chronic pain patient needs to understand that others may have missed signs that may be obvious on exam. In terms of neuropathic pain, which can lead to phenomena such as central sensitization, does the patient have signs such as hyperalgesia, wind-up hypopathia, color change, swelling, and trophic changes of the affected region? And does the patient have non-physiologic signs, such as inconsistent exam findings that could lead the evaluating physician to suspect a psychological component, exaggeration, or malingering? As previously stated, when formulating a treatment plan, the evaluating physician needs to have a firm concept of the role that he or she will play in the care of the patient. Once that's established, both internally and with the patient, the plan can then be formulated to address each component of the patient's problem. Often, it is suggested to move from least invasive treatments to the most invasive treatments, and to set goals and expectations that are appropriate. Unrealistic expectations often lead to the perception of treatment failure by the patient, even when the physician would rate that treatment as a success. Involving a psychologist experienced in the evaluation and management of patients with chronic pain early in care is also part of formulating a comprehensive treatment plan for these patients. While not all institutions can put a team like this together, the goal of establishing a comprehensive pain team is to have a multidisciplinary group of physicians, nurses, and other providers who can provide a set of services to the patient to address each component of a chronic pain condition. When implementing a treatment plan, there should be an established method for tracking the outcome. Many providers will use simple visual analog scale or numeric rating scale pain ratings. These are the most commonly used scales, such as 0 to 10 scales for patients rating their pain, but they are not the most robust or best measure for this. You may choose to use various established functional rating systems as well as patient-reported outcome measures that are publicly available to track the progress of the treatment plan. Again, this is important both to be able to demonstrate to the patient the progress that they have made on their treatment plan, and for quality assurance on the physician's part to understand the effectiveness of the plans that they implement. Once a plan is designed, you should try to stick with the plan and deviate from it as little as possible until each option is tried and failed. Also, it is good to lay out for the patient in the beginning an overall roadmap of the treatment plan and what the other options will be in the case that option A or option B tends to be unsuccessful. All this should be documented thoroughly in the medical record so that any other member of the patient's care team who sees the note can speak with a unified voice to the patient as to the pain care plan. And remember, not all patients that are seen by a physician need to be accepted for care, and at times the physician will make a decision not to accept a patient for longer-term care.